Hello. Today, my lecture is for the Annals of Cardiothoracic Surgery, and on behalf of my co-authors, we're going to talk about how to mirror tricuspid TEER to mitral TEER in terms of procedural imaging and device workflow, a step-by-step primer. Here are my disclosures. So the objective for this lecture is to mirror tricuspid TEER to mitral TEER, and there are three objectives highlighted here. One is to highlight the anatomic symmetry between the mitral and tricuspid valves. And two is to explain the in vivo anatomic differences between mitral and tricuspid valves. Third is to compare the technical aspects and imaging guidance of mitral and tricuspid TEER and highlight the key maneuvers that optimize procedural success and safety. This lecture will focus on the Abbott MitraClip and TriClip systems, given they are both FDA approved and commercially available worldwide. As we can see in this figure, the mitral and tricuspid valves are anatomically symmetrical across the interatrial septum. Adjacent to the septum are the anterior leaflet of the mitral valve and the septal leaflet of the tricuspid valve. Opposite to the septum are the posterior leaflet of the mitral valve and corresponding anatomically to the tricuspid lateral leaflet complex, i.e. the anterior and posterior leaflets. From a procedural perspective in TEER, grasping the anterior posterior leaflet of the mitral valve parallels grasping the septal and lateral leaflet complex of the tricuspid valve. The mitral valve consists of two primary leaflets, anterior and posterior, each further subdivided into three segments from lateral to medial, A1, A2, A3, and P1, P2, P3 respectively. The tricuspid valve typically comprises of three leaflets, septal, anterior, posterior. However, leaflet number and morphology can vary significantly in the general population. A standardized echocardiographic classification of the tricuspid leaflet anatomy has described the variations. Type 1 is three distinct leaflets. Type 2 is bicuspid with fused anterior and posterior leaflets. Type 3 is four leaflets which subdivided into A, B, and C depending on anterior papillary muscle position. And finally, type 4 is more than four leaflets. Leaflet grasping is typically performed between a leaflet located medially towards the aortic valve or interatrial septum and its lateral counterpart. In mitral TEER, this involves grasping the anterior and posterior leaflet. When anatomic variants are present, such as multiple segments for tricuspid TEER, the septal is grasped with either anterior or posterior leaflet, but the procedure becomes technically more challenging as there are more leaflet segments present. Here's the CT scan showing from the anterior chest wall inward. The anatomic alignment proceeds as follows: the ventricles, atrioventricular valves, atria, and finally the esophagus. However, due to the cardiac axis angling approximately 45 degrees to the left, the spatial relationship between the esophagus and each atrioventricular valve differs significantly between the left and right sides of the heart. In addition, the esophagus lies directly posterior to the left atrium and in close proximity to the mitral valve, allowing excellent visualization of the mitral apparatus with TEE. In contrast, the tricuspid valve is located further away from the esophagus. This greater distance results in reduced TEE image quality of the tricuspid valve due to attenuation and scattering of the ultrasound signal. As we can see in this image in particular, artifacts are common in patients with prior structural interventions, such as aortic valve replacement, mitral valve replacement, or mitral TEER, where prosthetic materials or implanted devices may create acoustic shadowing or reverberation that obscures tricuspid visualization. In such cases, three-dimensional intracardiac echo, or ICE, positioned within the right atrium, as you see here, offers a direct and unobstructed view of the tricuspid valve leaflets. ICE serve as a valuable adjunct to TEE, especially when image quality is compromised. So in this figure, you can see that the transcatheter aortic valve is shadowing against the septal and lateral leaflets shown here of the tricuspid valve. And you can see the shadow is quite intense as shown with the yellow arrowheads. And so you need to use ICE, position the right atrium, to be able to visualize the septal-lateral leaflets directly. Next, moving on to the general principles of the mirroring relationship between mitral and tricuspid TEER. According to the aforementioned anatomic relationship, most of the procedures are mirrored in the interatrial septum. After entering the right atrium, the first step is steering down to the valves. In mitral TEER, using the M knob to flex medially away from the lateral annulus to the center of the mitral valve. In tricuspid, using the F knob to flex the catheter centrally away from the septum towards the tricuspid valve. As depicted here in arrow A, advancing the system with the stabilizer in mitral moves towards the lateral commissure. And in tricuspid, it moves towards the anterior septal commissure. As depicted in arrow B, retracting the system with the stabilizer in mitral moves towards the medial commissure, and in tricuspid moves towards the posterior septal commissure. This is a 3D on-force view of both the mitral and tricuspid valves. And you can see that as depicted in arrow A, advancing the system in the stabilizer moves towards the lateral commissure, and in arrow B moves in the opposite direction. In tricuspid, it's moving lateral A, you can see moves to the anterior septal commissure, and arrow B, retracting the stabilizer, goes to the posterior septal commissure. Now, clockwise rotation of the guide, depicted in arrow C, in mitral, directs the clip towards the posterior leaflet, and in tricuspid towards the septal leaflet. Counterclockwise rotation, as depicted in arrow D, in mitral, directs the clip towards the anterior leaflet, and in tricuspid, directs the lateral, meaning anterior or posterior leaflets. Next, I'll show you step-by-step sequences of both mitral and tricuspid TEER side by side to visualize the parallels between the two procedures. First, in mitral TEER, transeptal puncture is performed at the posterior and mid portion of the fossa to create optimal runway for the steerable guide catheter, or SGC. In tricuspid TEER, this step is not necessary. So in this particular bicable and explain the reverse four-chamber view, you can see the tenting in the mid fossa here in terms of bicable view, and posterior on the reverse four-chamber view. And then you measure the ideal distance from the puncture site to the mitral leaflet coaptation shown is at least 4 centimeters. In mitral TEER, a stiff guide wire, such as the Safari wire, is positioned into the left superior pulmonary vein. The SGC initially inserted into the femoral vein with a negative deflection to keep it aligned with a straight configuration towards advancement into the right atrium. And then the negative deflection is neutralized, allowing the SGC to enter the left atrium with a gentle corkscrew rotation. Approximately 2 centimeters of the guide should be advanced into the left atrium to avoid popping out back into the right. In tricuspid TEER, the stiff guide wire is positioned into the superior vena cava via multipurpose catheter. And then the SGC advances up to the SVC-RA junction with the negative deflection maintained. The CDS, clip delivery system, comprising a steerable sleeve catheter and the DC fastener, is then inserted into the guide and advancing beyond the guide until the 2 radial opaque markers straddle the radial opaque tip marker of the guide. In mitral, the stabilizer may need to be retracted medially towards the septum to facilitate CDS advancement and straddle against the SGC, as you can see here on fluoroscopy. In tricuspid, the stabilizer needs to be retracted inferiorly towards the IVC as the CDS exits the guide to straddle against the guide, as you see here. Then, in mitral TEER, the CDS now is steered down from the lateral side to the mitral valve by flexing the CDS using the M knob, while simultaneously clockwise rotation of the guide to go more posteriorly. In tricuspid, the CDS is steered down from the septal side towards the tricuspid valve by flexing the CDS using the F knob, while simultaneously counterclocking rotating the guide to shift the CDS away from the septum. And you can see that here on fluoroscopy as well, on the mitral with M knob down, and then clockwise rotation of the guide. And here is F knob down, and then counterclocking the guide to get into the position to the tricuspid valve. Next, when adjusting clip position above the valve, you can see in mitral TEER, we use the bicommissural view with the apex oriented at 6 o'clock, and then explain that to the LVOT grasping view. In tricuspid, we use the TEE or ICE RV inflow view, explain to the grasping view, and you want to make sure the tricuspid annular plane is perpendicular to the ultrasound beam. And then you can also use multiplanar reconstruction on MPR and fluoroscopic RAL view to guide you as well. In mitral, advancing the stabilizer moves the clip from medial to lateral, and retracting the stabilizer moves in the opposite direction. Clockwise rotation of the guide moves the clip posteriorly towards the posterior leaflet, while counterclocking the guide goes towards the anterior leaflet. In tricuspid TEER, advancing the stabilizer goes towards the anterior septal commissure, and while retracting the stabilizer goes towards the posterior septal commissure. And clockwise rotating the guide moves the clip towards the septal leaflet, and counterclocking the guide goes towards the lateral leaflet. And you can see that here on fluoroscopy, on advancing the guide in the mitral TEER goes towards laterally, going up towards the screen, while retracting it goes to the bottom of the screen medially. And in the tricuspid TEER, you do the same by advancing the stabilizer goes to the anterior, and retracting it, as you see here, goes posterior. In an aerial fluoroscopic view now, the CD fastener is gently jiggled clockwise and counterclockwise to release the tension within the system and orient the clip without the parallax to approximately perpendicular to the coaptation line. Grippers are then raised, and you can see that here on echo in the grasping view, and the lock handle in the G4 system is raised, or in G5 system, the lock knob is turned clockwise, and this will unlock the clip. Clip arms are then opened to 60 degrees by rotating the arm opener counterclockwise. Tactile gripper is lowered first to identify the corresponding leaflet, and then the non-tactile gripper is lowered to confirm it's functional. Once confirmed, both grippers are then raised and the latch engaged, and these steps are common for both mitral and tricuspid TEER procedures. Next, we check the trajectory. Care for advancing the CDS towards the annulus without crossing the valve. In mitral TEER, in bicommissural and RAO view on fluoro, M knob towards the medial trajectory and L knob towards the lateral trajectory. In LVOT grasping view, clockwise the guide towards posterior leaflet and counterclock towards anterior. The plus-minus knob on the guide optimizes the AP trajectory in the case of an aorta hugger, where you can add the plus knob and then counterclock the guide to optimize the trajectory. In tricuspid TEER, the RV inflow and RAO view, you can see here the F knob goes posterior septal trajectory, and E knob goes anterior septal trajectory. In grasping view, however, clockwise the guide towards the septal leaflet and counterclock towards the lateral leaflet. In TriClip system, there's also an SL knob on the guide. In the grasping view, you can see use the S knob towards the septum and then counterclock the guide, or in the case of a septal hugger, L knob away from the septum towards lateral annulus, and then clock the guide back towards the septum to optimize the trajectory before entry into the ventricle. So here's what we mean. In mitral TEER, the plus knob on the SCG moves the clip away from the aorta in the grasping view. And then for example, with an anterior transeptal puncture with an aorta hugger, to correct it, you add the plus knob to deflect the CDS more medially in the bicommissural view, and then counterclock the guide posterior to more centrally on the LVOT view to what we call stand up the clip. You also, however, need to undo the M knob slightly to keep the clip perpendicular to the grasping plane in the bicommissural view. In tricuspid TEER, this is the same principle where the SL knob on the SGC does the same function to correct for the septal hugger trajectory. This is equivalent to the anterior aorta hugger and the mitral TEER. So what you do, you add the L knob on the guide to move the clip laterally away from the center, and then you clock the guide back to move the clip back towards the center to optimize the clip trajectory. Now, next on the 3D on-force view, you orient the clip perpendicular to the coaptation line here for optimal orientation for grasping. In mitral TEER, you construct using the bicommercial explain the LVOT, then you recreate this 3D on-force view or 3D MPL view. In tricuspid TEER, you use RV inflow explain the grasping view, and then you can create your 3D MPL that way, or you use the transcatheter short axis to identify the orientation. Rotate the DC fastener handle clockwise or counterclockwise to optimize the clip orientation. And once you confirm perpendicularity, you go to RAO projection to remove the clip parallax, and then when you confirm it on echo, and you document the clip orientation and send this image to serve as a fluoroscopic reference so that when you enter the ventricle, you can check whether the clip has spun or have any kind of dive laterally, medially, or anteriorly or septally. Now, as the clip enters the ventricle, always close the clip before advancement to prevent leaflet entanglement with the grippers. In mitral TEER, you use bicommercial view with explain to the LVOT grasping view and use the fluoroscopic RAO projection to check as well to adjust the clip perpendicularity and rotation. If you have a medial dive, you use L0 to shift more lateral, and if you have a lateral dive, you use the M0 to shift more medial. Anterior dive, you clock the guide more posteriorly, and posterior dive, you clock the guide more anteriorly. In tricuspid TEER, you use RV inflow explain to the grasping view. In anterior dive, you F0 to shift more posterior, and posterior dive, you use E0 to go more anterior. Septal dive, you counterclock the guide, and lateral dive, you clock the guide more centrally. You use also the fluoroscopic projection, as you might mention, to maintain clip perpendicularity by making sure the parallax stays free of that. And also, the clip does not dive in terms of trajectory, and you correlate that with echo. So once the clip is positioned below the target leaflet, the clip is open to 120 to 150 degrees. Then you retract the clip orientation using the 3D on-force or MPL view. And then you can use your fluoroscopic projection as well to maintain perpendicularity and no parallax as well when you come up to grasp. And now make sure you also have no trajectory bias when you retract the DC fastener to grasp the leaflet. So you retract the DC fastener to capture leaflet for grasping. And when you're ready, you drop the gripper slowly to lower during the diastole to engage the leaflets. A gripper bounce is a useful echocardiographic sign confirming leaflet insertion. Then you lock the clip immediately and close the clip arms partially to 60 degrees while you advance the DC fastener handle slowly to reduce tension on the leaflets and maintain the leaflet insertion. And in mitral TEER, you can see grasping is optimized. If you need to optimize the posterior leaflet, you go more posterior and clock the guide, or vice versa with anterior leaflet. Now, you need to make sure that you maintain the clip orientation on fluoro by micro-rotation of the fastener to make sure it stays no parallax. In tricuspid TEER, you can optimize the septal grasping by clocking the guide, or if it's lateral leaflet, you kind of clock the guide. Again, maintain the rotation on fluoroscopy to make sure that there's no parallax. So then you close the clip completely, as you see here, by still continue to advance slightly the DC fastener to bring the leaflet coaptation plane at or below the annulus. This is critical so that you don't lose any leaflet capture. And at the same time, on the mitral side, you have a little bit posterior guide torque to prevent posterior leaflet slippage. And for tricuspid, since the septal leaflet is usually shorter, you go slightly septal guide torque to avoid leaflet slippage there. You can measure the residual leaflet length and compare the baseline length to confirm adequate insertion. But in tricuspid TEER, the leaflet measurement may be less reliable because the tricuspid leaflet can stretch, and so it affects the calculation. Then you go to a 3D on-force MPL view to see the tissue bridge. You can see that here in the mitral valve with the anterior versus posterior leaflet. And tricuspid valve, you can do the transcatheter short axis view, or you can do it on the 3D MPL or on-force view if you can get a good image. Now, very important to evaluate for side biting of the leaflets for both procedures. And what that means is that the leaflets are not inserted into the center of the clip. Okay, so when that happens, that you might have color Doppler jet across the clip, and then that means that you do not have an adequate insertion and you have to optimize. So once you confirm leaflet insertion, you assess the reduction in regurgitation. In mitral, you do a systematic sweep from medial to lateral on both sides of the clip to check for the jet and also potential location for future clipping. And you can assess, making sure there's no side biting or inadequate insertion. In tricuspid, you do the same thing from posterior to anterior, do a systematic sweep for the same situation and anatomy. So then you check for the transmitral gradient for mitral, pulmonary venous flow, and LA pressure and V wave. And for tricuspid, you check for transtricuspid gradient, RA pressure, and V wave as well. So once we're ready to deploy the clip, first you check the final arm angle. In mitral TEER, you use the biconventional X-plane to the LVOT grasping view, and fluoroscopically go to the LAO projection this time to make sure you can see the two arms. In tricuspid TEER, you use the RV inflow X-plane to the grasping view, and on fluoroscopy, go to LAO view. And so you first, by rotating the arm opener counterclockwise slowly to the neutral position, and then additional 70-degree turn to ensure that the clip arms are fully closed and not reopened. And then you tightly close the clip. After increasing the infusion drip rate through the lock line, you slowly remove the lock line by first unscrewing the lock handle cap on the G4 system, and then removing the lock line, having confirmed no knotting on the either line. Or in the G5 system, you disengage the lock knob by raising the white lock lever. In G4, remove the lock line along the direction of the clip system. And in G5, you remove the lock line 90 degrees from the clip system as the lock knob is positioned on the side. Once the white lock line turns pink, that means the line is out of the CDS and you can remove the lock line quickly. Then, check the final arm angle again in the same way as in round 1. The final arm angle again is established by rotating the clip arm opener counterclockwise to the neutral position, and then additional 270 degrees to ensure the clip arms are fully closed and cannot reopen. And then this time though, go to a neutral position and not tighten. Finally, releasing the clip. In mitral TEER, this is done on the biconventional X-plane grasping view, and in tricuspid, the RV inflow X-plane the grasping view. Fluoroscopically, you go back to the RAO projection with the clip parallax removed, as you see here, and then you remove the safety pin to enable the through rotation of the arm opener. You rotate the arm opener counterclockwise until the groove in the actuator knob pin becomes exposed in the G4 system or in the G5 system until a hard stop. Rotate the actuator knob counterclockwise at least 8 full turns, and then pull it back to initiate the clip release, as you see here on fluoroscopy and on echo. Then you retract the gripper levers, and then you withdraw the DC fastener slowly to disengage the needle from the deploy clip, as you see here on fluoroscopy and on echo. Now, the final step is to retract the DC fastener back to the CDS. You can see that here. And then you remove the CDS back into the guide. So in mitral TEER, the CDS is directly either anteriorly or posteriorly as needed to keep it centered. And in tricuspid, you do septally or laterally to keep it centered. You might have to remove the plus knob in mitral guide so that it can be neutralized, and then undo the M knob as it disengage as you pull back into the SCC. And the tricuspid, you neutralize the L and plus knob, and the F knob is disengaged as the CDS is pulled back into the guide. You need to use TE to continuously monitor the metal tip of the CDS, the needle, throughout the retraction to make sure it doesn't injure adjacent structures. After that, you have applied gentle negative suction with a syringe and an extension to the guide side port during the CDS retraction to prevent air entrapment. Finally, the guide is removed and access closure is performed, as long as you don't need to apply and implant a second device. In terms of future directions, ongoing innovations and enhancement of imaging modalities, particularly 3D ICE to complement TEE, and echo fusion are essential to improve procedural guidance and outcomes. The latest generation MitraClip and TriClip G5 systems have certainly improved ease of use in both procedures. And further innovations will include more definitive confirmation, for example, sensor-based of leaflet insertion and easier optimization of delivery catheter trajectory for leaflet grasping. In summary, the spatial relationship between the esophagus and cardiac structures, as well as the orientation of the cardiac axis, significantly influence both TEE visualization and device navigation in mitral and tricuspid TEER procedures. While certain maneuvers such as steering the CDS towards the valve, using the M or F knob to flex the CDS, and advance the clip along coaptation line with the stabilizer are similar with both procedures. But clockwise or counterclockwise rotation of the CDS results in opposite direction of movement relative to the septum between mitral and tricuspid TEER procedures. To enhance procedural safety and success, ongoing innovation in 3D ICE to complement TEE, along with refinements in device designs, will be valuable, particularly in overcoming anatomic challenges in tricuspid TEER. Once again, on behalf of co-authors, I'd like to thank you for your attention in this lecture.